All right, good morning or afternoon, everyone. Thanks for being patient with us this morning. Looking forward to having a good, robust discussion on how to bring the flu vaccine to the community. We're going to let our very own Dr. Laura Lee Hall, who is the president for the Center for Sustainable Health at the National Minority Quality Forum, lead us on this effort. She has been doing the Lord or the yeoman's or whatever, lots of good work in this space for years now. And so I'd like her to go ahead and help educate everyone on the call. Thanks again, Laura Lee.
Thanks, Brandon. And I have been gifted to do some good work because of colleagues like those on this call. So I thank everyone. I need to be able to share my screen, Kiko. It says it's disabled. Thank you. We've had a little bit of as you've seen, a little bit of a snag. I guess it's the Halloween of this month. So let me put this into, I'm hoping everyone can see this. How to bring the flu vaccine to the community. So let me just do some introductions so we can get into the meat of it. I don't think that Gary Puckrin nor the National Minority Quality Forum need an introduction, but you know they've been a leader for more than 20 years in addressing health equity issues. And as the president of the Center for Sustainable Healthcare Quality and Equity, I've been with Gary now a few years, and we want to help use that data to empower clinicians and community leaders and others like you on this call to promote sustainable health in every single community. So how do we bring the flu vaccine to the community? I think we're all aware of the fact that there are many who are turning to non-traditional strategies for increasing flu vaccination. But how do you do that? And especially, how do you do it in diverse and underserved communities? Well, we're very fortunate that today we have the person who wrote the book on this, Dr. Ruth Carrico, along with two healthcare system leaders, Dr. Sacascio and Ms. Francis, who are actually implementing this in their systems. Now, you don't expect me to read this bio of Dr. Carrico. She's a leader at the University of Louisville School of Medicine. She's trained at some of the best institutions in infectious disease and epidemiology. She's had leadership positions in a number of organizations and has received numerous awards for her work. And as I noted, she wrote the book on the subject today. Again, Dr. Sacascio, I'm not going to read her bio, except to let you know she's the ambulatory chief medical officer for Prisma Health, and she's been leading numerous efforts to improve quality of care in this large system in South Carolina. She's a family medicine physician who's received many honors as well, and we've had the good fortune of working with her to promote flu vaccination in the last 2 years with some amazing results. Sheila Francis, who directs the Plaza del Sol Federally Qualified Health Center, is also a very important and successful healthcare leader. Under the founder and director, Helen Artiego, she's been integral to the work we've been collaborating with them on flu vaccination, despite being at ground zero for the COVID-19 pandemic, literally. And she's worked tirelessly to promote the health of her diverse patients through flu vaccination. And she's the one that's implementing the outdoor vaccination program. I was only going to remind you of the background of this activity, an action planning group that led us to find that we know how to increase flu vaccination rates, but there's a lot of work to be done because the disparities are continuing and even increasing nationwide, and COVID-19 just throws another wrench into the system. So how did our experts and stakeholders say we should proceed? All hands on deck. And that includes what we're going to talk about today, bringing the vaccine to the community, and especially to communities of color and those with low vaccine rates in the past and those hard hit by COVID-19. I'll remind you that we have a number of resources, and you see URL up here. I'll come back to it. But let me stop sharing and turn it over to Dr. Carrico to begin our conversation. Thank you, everyone.
Thank you. Thank you very much. It is a delight to be here, not only because as I'm hearing in the introductions, I'm thinking, oh my gosh, my friends that work at Prisma, oh my gosh, my friends that work at Montefiore. And so it just shows that this is another example that it is a very small world, and that in the scope of how we look at infectious diseases, COVID-19 reminds us that we are certainly our brothers and our sisters keepers, and that this is our responsibility as part of humanity. And this gives us a chance to, I think, stop for a moment and think about then what this means to all of us within our communities. So I'm happy to have the time to talk a little bit about mass immunization. And I want to try to frame our discussion thinking about vaccine availability, vaccine access, and then vaccine acceptance, because I think those are really the three important components. And I will, just as a disclosure, I'll tell you, I'm a self-professed, relentless vaccine advocate. I'll tell people, I was raised a Southern Baptist, and this is a pulpit that I have, and I'm feeling the spirit move me already. So at some point, Laura Lee, you may have to say, come on back down. If you have like the Zoom hook, you may have to put it out, and I will make sure to stay within my time frame. During our short period of time together, I want to talk a little bit about some of the drive-through methods. And I love, Sheila, you're talking about outdoor vaccine clinics, because I think that we have to frame these in a way that address our needs geographically, weather-wise, and with our populations, and how these methods then can augment the availability of vaccines. I also want to talk a little bit about drive-through as just one example of a process to facilitate access. So we have vaccine, now we're thinking about how we make sure people have access to it, and then a few of the barriers. And then finally, I want to wrap this all around that it doesn't really matter how available and how accessible if we are not at the same time addressing acceptance of vaccine. Then all of our efforts are hurdles that we have tried to go around instead of remove, and that may ultimately impact our success. So again, as I talk about this, I'm going to start a little bit about making vaccine available, and then you can see as vaccine is available, accessibility, or those that access available vaccine, decrease, and then those that ultimately accept vaccine decrease even further. So how do we flip this around and make these changes? Well, I want to start off with just some basic information that gives us an idea about how well we're doing. And I'm going to use influenza as the point of discussion, the vaccine of discussion, realizing that when we think about what is happening with flu, it is particularly and pointedly relevant to what is happening and what will happen with respect to COVID-19. So what do we need to learn from influenza? Well, here, this is just some information compiled over the years, looking at healthy people 2020 and healthy people 2010 and healthy people 20,000, before that time. And consistently what we see is that the older adult maybe kind of understands the importance of flu and maybe is developing a little sense of their own mortality and maybe their own vulnerability. So we have, these groups tend to reach a little bit closer toward those goals of 70%. However, look underneath that. We're not getting there in these other groups. So especially look at the under 18 years of age and under, we are improving in that group. And I think we all learned from the pediatricians that have the whole idea of combining vaccination and well visits and taking every opportunity to be looking at the child's immunization record. But then what happens when we move beyond the pediatric office? If we're looking at those that are 19 to 64, that's our lower age. And when we think about the relevance to COVID-19, where are we seeing then a lot of this transmission? It is in this younger age group. So thinking about then the realization or the acceptance of of my vulnerability, the getting rid of the concept of my invincibility, and then really bringing this home to groups of all ethnicities. It is quite a detail, but now let's look a little bit closer and look at vaccination. If we begin to look at the rates and look at it among ethnicities. So these are adults. So when we look at adults on the left compared to children on the right, you know, the children groups, we have a lot of greater success. And again, the pediatricians, I think, have gotten their arms around this very well. But once then the individual graduates from the pediatric setting and then is into primary care or no care settings, then we see our rates are significantly lower, but those rates among whites are higher. As across when looking across ethnic groups. And this is information from the Kaiser Family Foundation. So then a little bit closer, let's look then when we begin to take into consideration insurance. And this is from a publication that was just released I believe a couple of months ago. When we look at then immunization, influenza immunization run among non-elderly adults, and so these are adults up to age 64, we begin now to see an impact about, you know, where their healthcare occurs. Those that have private healthcare, private insurance generally have higher immunization rates than those who receive their healthcare in Medicaid or other public settings, and then those that are uninsured. Those immunization rates, as you would expect, are much lower. So then we begin to think about, all right, availability of vaccine, and then accessibility of vaccine. So we can see that having a place to actually receive the immunization becomes quite significant, especially when we're thinking about who might have to pay for that, because many of these vaccines are not free. Unless you have specific provisions for those, either through insurance or another mechanism. So kind of our questions that I want us to think about as we move forward is, you know, how can vaccination rates be impacted by making vaccine more available? And then does availability ensure accessibility? And then if vaccine is available and accessible, what's the impact of acceptance? So if it's available and accessible, what about acceptance? And then how does the presence of COVID-19 influence all of these aspects? So we mentioned the notion of drive-through vaccination. You know, drive-through vaccination is everybody stays in your car. You drive up. It's great because you're in your own little isolation unit. And this is a nice response as we're seeing that the general public is beginning to accept drive up or drive through or curbside healthcare for a variety of reasons. We're looking at everything from COVID-19 testing to, I think I read a publication about cardiovascular assessment and some of the cardiovascular devices, checking those devices via drive-through. So everybody is thinking more about how do I separate myself, or a lot of people are thinking, how do I separate myself from others? And I can continue to receive some types, whatever level of care or care intervention that I'm seeking. Drive-through vaccination also helps address some challenges in access and availability that we have kind of come to accept. So for example, if we're looking at what is happening in our pharmacies that are inside grocery stores or our retail clinics, that there still is the need to socially distance. So you can't have groups that we're getting together in the waiting room at the pharmacy or outside the retail clinic. So that ability to meet there may be less available. Vaccines that were provided at employer sites, if there are many members working from home, then some of those availabilities may be less. One of the groups that my team has worked with, where we used to go to a lot of sites across the state of Kentucky to provide vaccine. Now we're doing all of that through drive-through. So making that adjustment or adaptation has been quite challenging for the businesses, because this seems like it would be a really easy thing to do. And it is if you have some idea of the things to avoid. So for example, I went to one of the sessions yesterday for the drive-through, and They had a tent for me. It was pouring down rain. We were having some of the hurricane hit us up in Louisville. So wind was blowing, rain was blowing sideways, and they positioned the tent really close to a drainage grate in the parking lot. So, there were 3 inches of water that we were standing in. So, you have to give some kind of thought to how you're going to structure these drive-through events. And as Laura mentioned, that's why we put it all together in kind of a how-to manual and put it up on Amazon. So anybody that wants to learn from what we have experienced, good, bad, ugly, what works, what doesn't, then we try to share this information so you can think about this. And we know that drive-through vaccines can also be quite helpful for communities of all sizes. This is what our site looked like when we were providing the drive-through for the H1N1 vaccination several years ago, that we have a community of a little bit under 1 million. We certainly didn't have 1 million doses. We had 20,000 doses to administer, and we administered them in about 18 hours. So it can run quite efficiently. We learned that if you are going to have nurses administering the vaccine, that one nurse can administer about 60 doses of vaccine every hour. Easily, safely, but you have to make sure the process is supportive so that individual is not doing everything else in addition to administering vaccines. So we begin to use that type of experience that can help us then inform planning for how we might scale this both up and down. We've also learned that when you are looking at the logistics of some type of an event, it's important to think to take advantage of people with other skill sets. Maybe one of our problems in healthcare is sometimes we lack the humility that we need to have, that maybe others can bring important pieces of information to the table. So in planning these types of events, we quickly learned that engineers were vital to our planning. And just think, if the industrial engineers can figure out how Amazon and UPS and FedEx can do all their deliveries, surely they can help us with our planning for mass immunization events. So, we have learned a lot on actually how to conduct these events so we can structure them so we can make vaccine available. So availability then, augments with drive-through. It augments current vaccination sites, and it enables isolation and vaccination at the same time. So availability, I think, is easy to get our heads around. Now, what about accessibility? Well, this is a picture of our drive-through event. We were at a football stadium. We had tents. Here's the cars. Everybody was nice and organized, and we had cars of all sizes. I don't have the pictures of we had some people that came in with a flatbed truck and had their employees sitting on the flatbed truck, and buses that came in and, bringing individuals, vans that, I said, this looks like a circus clown car, because I couldn't believe there were so many people packed into these vans. Well, that was okay for H1N1. Now in the times of COVID, we need to recognize that we hopefully will not have all of those people riding together, but it might be, the family bubble that comes together in their van. So you need to figure out, how am I going to accommodate these people, and what does it do to the surrounding area, the traffic in the surrounding area. So again, I go back to the importance of engineers. But, this brings up the question about accessibility. So if I have a car, this is accessible to me. But what about if I don't have a car? Then I'm limiting my accessibility. So vaccine is available, I just can't access it if this is the primary way of doing that. So one of the things that we considered in our community was to say, all right, so where do we need then to have public buses that will pick up people from specific areas? So, we picked specific government centers. And it's interesting that we learned that the government center sounds great to us because we know the government center, but if that's not where the people will go, just because you have a bus there doesn't mean that they will go to that bus. So that whole idea of, build it and they will come may not be the right approach. That instead you need to understand and know your community, and you need to go to where the people will make themselves available to what you are trying to provide for them. So, we learned that having it at the government centers is not nearly as good as having them at the churches, because people will meet at their houses of worship, and that may be where they are used to being, and then we can pick them up from there. Now, I bring these heat maps just to kind of prove a point that this is some results from one of our pneumonia studies that looked at community-acquired pneumonia and the incidence of the disease and the severity of the disease. So this is the incidence of community-acquired pneumonia. We're looking at it, by population. If you're wondering why we've got what looks like that big kind of, empty finger area in the middle, that's where the airport is. So we don't have any population that lives there. But if you're saying, hey, I want to live in that area of town, well, you'll be living on a runway. So that's not the option at this point. But as you look across, look at, this is where pneumonia was identified, and these were hospitalized patients. These are individuals with severe pneumonia. That means they were hospitalized and may have had even some intensive care interaction. And now we gathered this information because part of our research is we have teams in all of the Louisville area hospitals, so we can look at what was happening across the population. But look at the bottom picture. This is our area of poverty, using then information, statistics from the U.S. Census Bureau. So this tells us where our disease is occurring and where we need to focus our resource and our efforts. And interestingly, if I layer on top of COVID-19 and where we have seen COVID-19, both the incidence and the severity, it lays right on top of this community-acquired pneumonia. So we know in our population where our population needs us the most. So this tells us where we need to be if we are thinking about not only availability of vaccine, but who needs to access vaccine. So this takes us then to a reminder that accessibility makes it easier to get vaccine, and it takes a step toward removing barriers that prevent the connection of people to the vaccine. But that's not the whole answer, is it? We need to make sure that the population will accept it. And so many of us have spent a lot of time talking about vaccine hesitance, and I tend to divide this into vaccine hesitance and vaccine confidence, because when I talk with my patients about immunization, those that, and I have the whole gamut, I have the whole bell curve, those that, as soon as vaccine is there, they're going to be lining up and they're, knocking on the door ready to have it. Those that would not be vaccinated under any circumstances. And then the majority of my practice is in the middle. But I spend a lot of time with the people at the end where every time they refuse vaccine, they know I'm going to talk to them about it next time. That is kind of like smoking cessation. Every time we meet, I'm going to be talking with you about vaccination. But my patients have two areas of concern. One is, does the vaccine hurt me? And they want to know about adverse events. They also will remind me about historical ethics. And, I will hear regularly about, I'm afraid of that because remember, when my family member, my grandmother, my grandfather was injected, was subject to unethical research. So we're still having to address that. And if we act like it never happened, we will not be able to get around this and make these changes. They also asked me, well, who's going to inject me? They don't want somebody they don't know. That this is all part of a conspiracy process sometimes. So we need to understand, what is involved in vaccine hesitance beyond just kind of those superficial questions sometimes that people ask us. Not, is the shot going to hurt? Is my arm going to be sore? People have more serious, deeper questions and hesitance than that. But they also at the same time have vaccine confidence issues. And they want to know kind of, is the juice worth the squeeze? Is the, what's the risk benefit? Will this vaccine actually help me? So should I accept the risk of the vaccine if I don't really appreciate the benefit? So these conversations with our patients need to be embedded into all of our discussions. And so I'm going to use a couple of case scenarios, and I don't want to take up a lot of time, but I just want to go through some of our experiences and share with you what we've done. So we have a really active, very big international travel clinic. We see a lot of people going on mission trips. So this was our observation during one season. We had 5 different church mission trips. All of these 5 were going into areas where they needed yellow fever vaccine. Now, I'll remind you, this was several years ago when we were not restricted with vaccine yellow fever vaccine, and we would regularly take vaccine out of our environment, put it in our mobile units, and then follow all of the requirements. We're very attentive to care of the vaccines, but we at this point would take the vaccine to the group that was going to be vaccinated. And it was interesting. In these 5 church mission groups, we had 2 distinct separations. One of those, a large number of those individuals wanted to be vaccinated at the church, and we would arrange it either on Sunday or Wednesdays, seemed to be their big fellowship days. So we would see some at the church, and then others in the office who couldn't be there at that period of time. But we began to notice a distinct difference, that if the minister was present, everybody got exactly what the minister got. If the minister wasn't present, then we had a lot of groups that were much less likely to be complete in their vaccine. So we noticed a big difference in the acceptance of typhoid vaccine, Tdap vaccine, and hepatitis A. And these were not in periods of time where we were looking at influenza specifically for this. But my point was that we noticed dramatically, and it was interesting, that the entire clinic said, did anybody else notice that we had this big difference? That whatever the minister said he or she was going to be getting, everybody got those vaccines when they were with the minister. But if they were not subject to what he or she was doing, then that changed everything. So that let us know right off the bat that we needed to be considering making some changes. We also had another situation where we had an on-site influenza vaccination at a very large local church, and 2 people were on the team. One was a nurse who was not a church member. The other was a pharmacist and was a church member. And look at their scorecard: nurse 12, pharmacist 56. So the people in the church were much more likely to be vaccinated and to seek vaccination from the one they knew. And in fact, there were situations where they refused vaccination from the nurse, but they came back later and would be vaccinated by their church member who was the pharmacist. So a lot of differences among those populations. But my group then took note of this, and we said, okay, we've got to start addressing vaccine acceptance, that we were having it available. We thought we had everything good. And so we learned some things. And with the mission trip, it's like, okay, mission trip planning always starts first with a conversation with the minister or the pastor or the priest to say, okay, this is what we think with your itinerary. This is what we think needs to happen. And that if we can provide the vaccines on site at the church with the minister, that's our goal. We do everything that we can. It doesn't matter what scheduling is. We do everything that we can to make sure that happens. And if the mission trip members are seen in the clinic, we try to avoid group counseling unless they have already met with their minister, or if the minister is part of that group, that we try to avoid that we try to bring in the influence from the person that is likely to be the most instrumental in their acceptance. And now, as a nurse, this is really hard for me to accept because, we hear all the time, nurses are the most trusted profession. And sometimes I take that for granted. And so I'm sort of shocked if I will give somebody a recommendation and they tell me no. Sometimes I don't quite know how to respond. It's like, what did I do wrong? Instead, it's like, I need to figure out what I need to do right. And I need to make sure that I'm understanding that person. It's that whole kind of theory. Those of us in nursing, we talk about transcultural nursing. We need to go to where the person is. It may not be geographically, but I need to meet them where they are and understand who they are, so I can help then figure out what they value and how I can support that. So acceptance then becomes the most critical part of immunization, that the impact of the vaccine to prevent illness may not be a driving factor. It may actually be who they trust. That's the driving factor, or the role model, or the person that has the most credibility. So as we're putting together then, and as we're beginning to think about where we're going to go with COVID-19, then we are flipping this all around, that the first thing we're thinking about is who is going to be the person most likely to influence acceptance. And then we're building access and availability around that critical piece of information. And so that means we have to be going to groups and we have to understand their hesitance. We need to understand their lack of confidence. We need to sometimes debunk to the best of our ability myths, but they may not want to hear it from us. It may be through another party. So I think our take-home message that we have to focus on acceptance as our primary area of emphasis. We've got to look at how we engage with the community. And again, it's not that they engage with me, I engage with them. So my perspective has to be different. I've got to have credible role models. I've got to have trusted voices. And I've got to then recognize if I'm going to make immunization available in this time, the time of COVID, that I'm going to have to do so in a way that is safe for everybody. So I'm going to have to be willing to think differently. I'm going to have to be willing to listen to others and accept what they are suggesting. And I need to look at the groups that we know as a community are critical as part of our being part of the human race. We've got to be looking at others, and we've got to be thinking about others, and we've got to be recognizing then groups that typically and historically have not been our early adopters or even our late adopters, our naysayers. We've got to focus on them and somehow then figure out how do we make them realize that their importance is just as important as my importance. That at this point we're all the same. So let me turn this back over to you, Laura, and I appreciate the opportunity to be at the altar and be able to have a few minutes at the church podium.
Ruth, that was really wonderful, and I learned a lot from what you just described. I want to hand the mic over to Dr. Sakashio. I don't know if you have slides or not, but if you want to share some slides, that's fine. Tell us about what you've been doing and what you've learned, Saria.
Yes, thank you, Laura Lee. And Ruth, that was fantastic. Thank you so much. I was taking notes as you were talking, and I think very important concepts that you bring up. And I think what you said was key in regard to the availability, the access, before you can even get to the acceptance. Those two have to be in place first, and certainly in parallel as we are gaining acceptance from our communities. That is just so very important. So I've already been introduced, and thank you so much, Laura Lee, for that introduction. I would just want to take a few minutes to share our story at Prisma Health. We are a South Carolina-based health system across the acute care space, ambulatory, and post-acute. We have been integrated in our communities and recognize that the availability piece and our partnership with our pharmaceutical companies has been essential to make sure that we had adequate access to the vaccine ourselves before we could then provide the access to our patients. And what we've done differently this year in light of the COVID-19 pandemic is we brought together for the very first time a flu immunization touch point task force, if you will. And this reached across every encounter point with patients, but also included all of our support stakeholders within the system. So there are over 100 people who connect with, on a weekly basis, the strategy across the system. We had an aggressive goal to achieve at least 200,000 internal vaccinations within the system, knowing that's a small part of our patient population, which serves approximately 1.2 million people. And we have partnered with our community institutions such as pharmacies, schools, and all the other areas that we need to make sure that access is provided. And so for that reason, this has been a learning year for us, and we have great plans for next year because of what we've learned this year. What we recognize is even within our system, we still had the myths that existed. And it wasn't until we created one FAQ, or frequently asked questions, that was shared across our health system, be it in the ambulatory space, in the hospital space, or with our post-acute care folks and in our community, that certainly made a difference in our work. We recognized that a health system-wide approach was critical going forward. We set up through our drive-through testing sites that were originally hosting COVID-19 testing. We now have lanes available for patients to receive the flu vaccine when they're not symptomatic. Of course, we recognize that's that contraindication that we have to be aware of. But again, using sites that already exist, where we have practices that offered Monday through Friday, 9 to 5 or 8 to 5, vaccines. Now they're open in the evenings, on the weekends. And there's been a tremendous amount of excitement and commitment from the entire healthcare team that this is critical. And it took the leadership from our nurses, from our physicians, all of our providers, and our operational leadership to make this successful. So I shared with you that we've had a goal of 200,000 vaccines to be delivered. As of yesterday, we currently hit a number of 82,115 out of our 200,000. Our employees so far, we're at 19,162, and we have over 29,000 employees that will be vaccinated by next week. So this has been tremendous work, but the fact that we even know this data exists is a sign of the focus and the energy that's been important in our system. We now have a flu dashboard that's looking across payers, across gender, across our different ethnic groups to make sure that where we've had a miss or we have opportunity, now we are addressing where we have our free flu vaccines in the future to make sure that's where those resources go. In the past, it was very disjointed, and a hospital facility would decide to place a free flu shot clinic event just because that's where the dollars were. Well, going forward, that will no longer be the case. So this is where that information that you shared, Ruth, is so very important to recognize who needs it and who's not getting it. Where's the access issue? Let's address that. So we have the flu vaccine accessible in every community, in every neighborhood. But then that acceptance piece, that acceptance language varies. And this is what we've learned because of COVID, and thank goodness for our Hispanic partners in our communities, is the message is very different. Where we're connecting, where we're building trust, how we message this information can be different. And as you said, we connect with our community. We shouldn't expect our community to connect with us. I think that's very important. I had a couple of other notes that I shared as we learn from one another. As I mentioned, we're going to the sites, so we're going to the churches, we're going to the schools. And where in the past we may have met resistance from parents or from teachers or school systems, there's so much more integration now. And my hope is that this continues in the future as we go forward. We've also recognized where we may have resistance. We update our FAQs. So if we're hearing a new story, for example, at one point, there was a concern in our African-American community that what they heard was that the flu vaccine actually increases the risk for COVID-19 contraction. And so clearing that up. And I think as we keep this a fluid document and we answer those questions as they arrive, we're building trust, we're building transparency and spreading that message as we go along. Now, I know that we still have Sheila who wants to speak, so I'm going to pause, and we want to save time for questions and answers. So I know we have so much more information to get to. So again, thank you for this opportunity to participate.
Thank you, Saria. And I've always learned from you how someone who likes to, someone who wants to improve quality can really use the numbers to great effect. I think you do it better than almost anyone. So let's turn to Ms. Francis. Sheila, tell us about what you are doing in Corona, New York.
Good afternoon. Can you all hear me? Yeah, thank you to my other two panelists and Dr. Laura Lee. Of course, I'm in a much smaller spectrum in terms of healthcare. I belong to Urban Health, an FQAC site system of 10 to 12, including school health sites. I'm in the second biggest sites in Corona, Queens, a very diverse minority centric community. Very highly Hispanic, highly uninsured patient who was very much hit by Corona and COVID. No pun intended on the name. So, you know, our challenge was post-COVID, how do we get everyone vaccinated? We have 1,400 square feet at Plaza del Sol. Our waiting room had a standing of 90 patients, and we went down due to social distancing to 32. And I have 16 plus exam rooms and other ancillary services. So this was the challenge. Here we are, start of school season. From May already, we were one of those clinics who did not close through it all. we were the backbone for Elmore hospitals, where Elmore Hospital was people were making line, and really Corona was one of those hardest hit boroughs. And it really told a story about inequality and poverty and access. And COVID was one of those things that highlighted it. From the get-go, from May, I was planning, how are we going to get COVID testing, one, and how are we going to get our flu vaccines and everybody vaccinated who at this point, we already had a backlog of people who did not get vaccination from, March, May, June, all these children who were not coming in. Although we did not close, although we didn't turn anybody away, people were not coming out because the instructions were stay home and under no circumstances come out. So I had to convince my CEO and my AVP and the whole organization to get behind 10th vaccination. They've never done this before. And I started designing it with the medical director, Dr. Matthew Kusher, and how we were going to do this. Was this going to be a one-time event? Was this going to be an everyday situation? Am I like dismantling and putting it back every day? And I got the CNO behind me, and we wrote out a policy on how to, the other challenge is, if refrigerators, medical refrigerator, it's not something you can move in and out of a clinic, because then you don't have, it's not calibrated and it won't give you the right reading. So then I had to, incorporate coolers. I had to get MIS to get behind me and activate Wi-Fi or hardwire by computers. So now we are, my organization went through a very terrible economic hard times during COVID. Now I'm asking for funds to get a laptop, to get all these other things that I need in order to get this going. And it was very successful. We were at the peak, we were vaccinating about 100, 150 people a day for the flu vaccine. I want to share the picture of it if I'm able to. Okay. So this was my algorithm on how to come into the clinic. And, we had to have a series of questions to come in and temperature taking, and I'm sure you all did that as well. And we already knew that we weren't going to run into capacity. We always kept a respiratory side in my clinic. We had an isolation unit for the COVID patients, as well as the well visits. So we divided our clinics into two areas. We kept doing standard vaccinations inside, but the key was the flu vaccine. How do we drive the flu vaccine and make sure people are not discouraged by the line, by the 1,000 questions we're asking in the front, by the lack of space, by possible infection of COVID. So the solution was the tent. And this was my proposal at the beginning from May, and what the equipment I was going to need, where I was going to place it, and the staffing I was going to need, and the reasoning behind it. This is outside my clinic and was going to be part of right around the exit of the south side to make sure that we had access to hand washing and supplies. And at the end, this was the tent outside the clinic. It was something we had facility install in the morning and dismantle in the evening. So it was every day until weather permitting, that we did that. And we're happy, some of the myths surrounding the flu vaccine in terms of the Spanish community, it was that, oh, I don't get gripe, if you heard that term. And we have to inform our patients, influenza is not gripe. It's way much more. But this year, we definitely saw people being open to it. People who had not been in the clinic for years were coming just to get that vaccine. We had the call center making direct appointments in our nursing template. We had people walk in. We basically, we knew and we prepare for us to be accessible, for us to educate, and for us to not let anything become a barrier for our patients to get the flu vaccine. And it has been very successful so far. In New York City, we're going through a storm right now. so we don't have a tent today. But hopefully we can, reinitiate it very soon. We ended up getting heaters, portable heaters, in order for our staff to be okay and for patients to be safe and not have to feel very cold outside, but it has worked out fine. And that's part of my story. Thank you so much.
Sheila, that's so wonderful. I can't wait to come back to the clinic there. We have some questions that were provided and also on our chat board. So we can go a little long since we had some Zoom problems to begin with, if you don't mind. I know that one person has asked if they can get a copy of Saria, your FAQs.
Sure. Would it be best to send that to you, Laura Lee?
Absolutely. And I can provide that. There was I'm going to save this question for last, but there is a question about the child vaccination rates between 08 and 09, Dr. Carrico, that was asked, but let me turn to the other questions that we have. So one is, has anyone found that one type of publicity for a flu event works better with a certain population than another? And I'll just let
I can offer a few words there, because we've really focused on this recently and tracked the number of outreach encounters that we've had with our media. And the more often we could get on the television, I think has had a significant impact in the older population that is still watching the news on public television. But what we've also seen to be tremendously helpful is social media. Social media is reaching our younger generations, perhaps those where we saw from our data earlier that we're not capturing as many people. So when they hear from their peers, when this is on Facebook, whenever we send it out through Instagram and other places, they're connecting with it, especially when it comes to younger families. And now offering the vaccine at our pediatric clinics for both the parents and all the children together. This has really been helpful. And in those messages, we constantly send them back to our webpage. And we share that this is information that will be updated constantly. As I mentioned, our FAQs get updated. Our free flu clinic sites are also listed there, and all of the locations where people can go to receive this information. So that continuous message and one webpage that is fluid and frequently updated has been very helpful.
Yeah. Any other thoughts?
I agree with that. Then I think that, your communication has to be very intentional with individual groups. So who is it that, where do they go? So, I start off, it's great to work at a university because I'll ask the university students, if I want to reach, your age group, what do I do? Who do I talk with? I always, public health is our best friend. And, everything that I've learned about vaccination started with my colleagues in public health. So I'll ask them, what are your experiences in these areas? The family health centers, the federally qualified family health centers, who are the target people? And every clinic or every group has somebody that's really influential in that, in that area. So find out who those influencers are and then ask them, how would you communicate? What is it that people like? We've learned things like the Cuban newsletters in Louisville. If we want to get something out to the Hispanic population, we need to know the guy that owns that newspaper, and we take out an ad. Or, these particular church groups, or we've, gotten people that are in the mosques. And so, it's that, to me, that's a whole new, I always learned about community participatory research. But this is a whole new thing. This is maybe not the research side. It's just the basics of how do people connect. And, we've learned a lot that, people, my age, I'm on Facebook. I don't actually know how to do anything. I'm more, I read what everybody else posts. Every time I try to post something up, one of my kids will say, Mom, did you actually mean to post that? And I'll say, no, how did that happen? And, so I realize that I don't know, how to do that. So one of the challenges I have in, one of my areas of focus is I've got to know a lot of people that know how to do a lot of things, because I don't know how to do a lot of things. So, who are those new relationships that we need to build?
Well, building on that, there's a question specifically for you, Sheila. So how did you inform your community about the availability of outdoor vaccines?
So Plaza del Sol in general is very active with community leaders and other nonprofit organizations in the area. That's one. Two, we also vaccinate our public officials like Jessica Ramos and Alexandra Ocasio-Cortez. They come and do a whole live thing, IG live. We're getting vaccinated. We're here at Plaza del Sol, and we're promoting not only the flu, they're promoting themselves, and it's a partnership. So another thing, we have partnered with Grow NYC New York, and we distribute food and fresh vegetables to the community. And part of it is let's talk about the flu, let's talk about COVID testing, and really engage them in that way.
So another question that came in is, how do you think this flu vaccination effort will lead into COVID vaccine efforts, hopefully in the not too distant future? I heard, Saria, you talk about you're going to do this again. Let's talk about sustainability and this interlacing with COVID.
Sure. So this is what's different for us, is the pairing together with the community needs, as I alluded to before, and where we actually used to deliver care. So we'll continue to deliver care certainly across our system. At the same time, we have been enlightened in the areas that we haven't previously covered. So now we have communication channels that have been built. Those relationships will continue, and we'll have a system-wide approach. For example, particularly with the flu vaccine, we'll start planning in May, June, but rather than within our silos of ambulatory care or post-acute or acute care and others, we'll come together and determine as a collaborative, where do we believe will have the greatest impact in access and acceptance with these medications, with our flu vaccine in particular, and what messaging do we need to be very specific about? I think we have technology now that has empowered us to give very personalized messages so that people are hearing what they need to hear to build trust. So what they need to hear from a factual perspective. So there's a tremendous opportunity. And I think this year just opened our eyes to all the different ways that we can do this through data, through connection in the various places where we connect. And I heard just a moment earlier, as we talk about our community healthcare leaders and where we connect, whether it's a community church bulletin, or what we've seen is that in our Hispanic community, the grocery stores, this is where everyone goes. This is where everyone is connecting. How are we messaging and building those relationships? We've got to become much more personalized to develop a more equitable, accessible approach and acceptance.
I don't know, Ruth or Sheila, do you want to comment on how this leads into COVID vaccine?
I think with us, we're spending now a lot of time in the west end of Louisville, the area where is that high disease incidence and highest poverty areas, to connect in with the clinics. That there are a lot of free clinics, a lot of nurse practitioner run clinics that are in the area, and saying, what is it that you need? We're using the Kentucky Nurses Association to pull in individuals across the community to volunteer for efforts. We just donated, my group just donated a lot of flu vaccine to say, okay, can we begin to develop these relationships and immunization? So like if the clinic leaders will publicly be vaccinated, so everybody sees, what will that influence as far as accepting flu vaccine? And then that gives us the ability to go back and say either, clinical trials are available, because we know that we're not going to have availability, at least we don't think, unless, something changes, we're not going to have enough vaccine for the 350 million people in the US to have access immediately. That it's going to be, brought into communities probably much more slowly than we would like. So that means without clinical trials, we will have a lot of high risk people in the general public that may be without the ability to access an FDA released, even if it's emergency use authorization, to access that vaccine for months, maybe a year or more. So how do we then get people to be willing to enroll in a clinical trial? That's going to be a huge issue, but that may be one of the things that we have to really focus on if we're going to stop, somehow get ahead of this outbreak.
Sheila, you have any other?
I think it's going to be a big undertaking. There's a lot that we don't know. I could tell you Corona is 50% antibody positive. They already went through it. Are those folk going to be eligible for the vaccine? I remember when COVID testing came out, nobody could get a COVID testing. You have to have, symptoms, be of some sort of exposure. Is the vaccine going to be handled in that same format? Who's going to be prioritized? Is it going to be, is poverty and access going to play a part, or is it going to be equitable? I mean, I don't know.
Well, I want to let everyone know orally, it's in the chat, that we will be sharing the video of this and slides, and we won't get to all the questions, obviously, but I will share the questions with our panelists. One last question. We've had a couple of questions about use of door-to-door vaccines in senior housing buildings, or use of medical mobile units or community health workers. And I don't know if any of you have any comments about that.
Yeah, no, we've spent a lot of time in how do we do that and how do we support. A lot of this is occurring through public health and public health initiated interventions. And, unfortunately, public health was kind of largely dismantled. In many places, there was this thought that with the Affordable Care Act, everybody will have a provider and therefore everyone will go. Well, we know that that's not how it worked. And so, we have a lot of policy emphasis, but not a lot of what I call doers. And that is unfortunate that those things have to happen together. So we don't have the capacity in public health. We have people that are extremely knowledgeable about what needs to happen, but it is our responsibility then to go to them to say, how do we help? What do you need? And so again, I go back to, like in our area, going back to our State Nurses Association, where we've developed things like using Sign Up Genius, where we'll say, public health will say, this is what we need. We'll put the announcement out on Sign Up Genius, and those people that have volunteered can say, oh yeah, I can help here, or I can do that. And that, we have to do a lot of background about training and competency development and license verification and, those types of things. But, this is a way to bring out the innovation. We've got the entire world that is focusing on one disease, and how one disease is impacting us. So, people have these great ideas. And to me, that's the exciting part, to look and see what people are thinking and coming up with. Now we have to provide a conduit. So we're taking advantage of all of this and putting all of these, these great ideas into play to help your communities. But, COVID-19 is both, as everybody has said, our response is local. So we are responsible for understanding our local community. And then, and you do it till it hurts. You are helping and you are working until it hurts. If it is not hurting, you're not working hard enough in the midst of this pandemic. And I would challenge anybody who is comfortable and sitting at home you need to hurt a little bit, just like your community is hurting. So find out where you can be active and make your life count. At the end of the day, everybody wants to feel like my life made a difference. What I did made a difference. Now is the time for that to happen. So find out how you can get involved. Call your local public health, your local health department or health district, and say, how can I help? To get out to them. And I'm sure that they will.
I, in the interest of time, I think that that's a very wonderful way to end our conversation. Not that I want everyone to hurt, but I do think that the people who are on this panel, and really everyone listening in, wants to make a difference. And this is an opportunity to be innovative and share our innovative activities with each other, because we are learning together and making a difference together. It is such an honor to work with you three ladies today, with Brandon and
Thank you.
Coco.
Same
And thank
here.
you all you participants out there. I will share your questions with everyone and we'll get you the materials from the meeting. Thank you.
Have
Thank
a
you so much.
wonderful afternoon. Thank you. Bye-bye.
Bye-bye.